Hi everyone, today we are going to discuss about polyhydramnios. So before going into polyhydramnios, let's see disorders of amniotic fluid. So amniotic fluid normally increases in amount throughout the pregnancy, like from few milliliters to a liters till 38th week. So the fluid is not static, the water and solutes in it are changing every few hours. So there are two chief abnormalities can be seen in this amniotic fluid. First one is polyhydramnios, the other one is oligohydramnios. So first let's see this polyhydramnios. Definition of polyhydramnios. Polyhydramnios is a state where the amount of amniotic fluid exceeds 1500 ml. So if it is exceeding more than 1500 ml, that is polyhydramnios. And it states that the excessive accumulation of liquor amni causing discomfort to the patient, and even we cannot able to imaging help like substantiate the clinical diagnosis of the life. Like suppose the baby will be in like oblique or transfer, so which lie, so the baby will be floating due to that excessive amniotic fluid. We cannot able to diagnose that the baby in which presentation as well as which lie. So that means the fetus will be in unstable lie. And let's see the incidences and etiology. So polyhydramnios occurs 1 to 2% of pregnancies. It is more common in multipara than in primipara. So minor degrees of hydramnios are fairly common and occurs in 1 in 1000. So exact etiology or exact cause of excessive accumulation of amniotic fluid still speculative. That means unknown. And it may be result of the deficient absorption as well as the excessive production, which may be temporary or permanent. So while there are four causes have been found, first one is a fetal anomalies. So this congenital fetal malformations will cause about 20%. So there may be a chance of 20% related to fetal anomalies like anencephaly, open spina bifida, and esophageal or duodenal atresia, facial clips, and mostly hydrops fetalis. Hydrops fetalis. So this hydrops fetalis is a condition occurs when the large amount of fluid build up in the body's tissue and organs, which causing extreme swelling. So these are the four causes: anencephaly, open spina bifida, esophageal, duodenal atresia, and hydrops fetalis in the fetal anomalies. Then maternal causes. So maternal causes like diabetes mellitus, cardiac or renal diseases, and placental factors like choriocarcinoma of the placenta and multiple pregnancies. So in this multiple pregnancies, especially with monozygotic twins. So these are the usually affecting the second sac. So let's see the clinical types of polyhydramnios. So there is chronic polyhydramnios and acute polyhydramnios. So let's see chronic polyhydramnios. So depending on the mode of the onset and progress, there are divided into two of polyhydramnios. First one is the chronic polyhydramnios. So this is the most common type, which is gradual in onset, usually from about 38th week of pregnancy. So in this chronic polyhydramnios, it mostly occur in the 38th week. There will be a uterine enlargement. So the abdominal girth and fundal height are far beyond the expected for gestational age. Imagine when the fetus should be on like 24th week till umbilicus, but if it is still in 16th or 20th week, the fetus is growing above above the umbilicus. So that means the gestational age is lesser than the abdominal fundal enlargement. So here, and also tenses of the uterine wall, making it difficult or impossible to auscultate fetal heart tones and cannot palpate fetal outlines. So due to that excessive accumulation of amniotic fluid, we cannot able to hear the fetal heart sound, and as well as we cannot able to palpate the fetal parts. And mechanical problems such as severe dyspnea, lower extremity and vulvar edema can be seen, and pressure pains in the back, abdomen and thighs, and nausea and vomiting can be seen, and frequent change of fetal lie, as I said before itself. So that is you can call it as this like unstable lie. Next is the acute polyhydramnios. So this acute polyhydramnios is extremely rare. The onset is acute. So the fluid accumulates within a few days, and it usually occurs before the 28th week of pregnancy. And it is often associated with uniovular twins or choriocarcinoma of the placenta. Here we can see abdominal pain, nausea, vomiting, edema of the legs. Abdomen is hugely enlarged in relation to the period of gestation with tense skin, like shiny skin you can see. Fetal parts cannot be felt nor the fetal heart audible. Fluid thrill will be present. On internal examination, dilation of os, taking up the cervix and bulging of the membranes can be felt. So under ultrasonography, this may reveal fetal and or placental anomaly. So these are the clinical types. Management. Most often spontaneous abortion occurs. So in these cases, mostly spontaneous abortions can be occur. So, and decompression of uterus. Decompression of uterus is nothing but sudden loss of amniotic fluid from the uterus. So if it has to be done. On rare occasion where the baby is valuable, then they go for repeated amniocentesis. Suppose if they wanted to continue, then only they have to go for repeated amniocentesis. And after excluding the fetal congenital anomaly, so let me explain about amniocentesis. So here withdrawing the fluid, amniotic fluid from the uterus. So here, otherwise pregnancy, if after excluding like fetal congenital anomalies are present, if we know that there is a fetal congenital anomaly, then definitely they should go for termination of pregnancy. So this is about the management. Supportive therapy. So before, in severe degrees of hydromnias, in view of the risk involved high perinatal morbidity, so the patient should be managed in a hospital equipped to deal with high risk patients. So supportive therapy, bed rest and treatment of associated conditions like preeclampsia. If there is preeclampsia, that should be treated. And investigations to exclude congenital fetal malformation. So if there is fetal malformation, so then I already said that pregnancy should be terminated. And further management will depend upon this response to treatment. Like if the response to treatment is good, pregnancy will be continued. Period of gestation. So before 28th week, they can go for abortion or termination of pregnancy. And presence of fetal malformation, then they should go for termination of pregnancies. If there is associated complicating factors, so that should be, if unresponsive and pregnancy is less than 37 week, amniocentesis and termination of pregnancy is done. For unresponsive pregnancy above 37th week, you see Below 37th week you can go for termination of pregnancy, but above 37th week can go for induction of labor. Induction of labor. Remember, above 37th week, before termination of pregnancy. Before 37th week, termination of pregnancy. Above 37th, induction of labor. During the labor, usual management measures are followed. If the uterine contraction becomes sluggish, oxytocin infusion may be started to prevent the postpartum hemorrhage, and IV administration of methergine also will be used. Next is complications. So there are fetal and maternal complications. So here mostly fetal complication. So most in cases of polyhydramnios, in 30 to 50% of cases will be going for termination of pregnancy. Here perinatal mortality can be seen. So this the death are mostly due to the prematurity. Next, fetal subinvolution of the uterus and increased puerperal morbidity and increased blood loss can be seen in the woman. Prevention. So prevention, in recent time there has been a falling trend in the incidence of hydromnios. So early detection and control of disease. So if it is early detected of polyhydramnios, and then we can control, and genetic counseling is an important factor in early months, and detection of by detecting of fetal congenital abnormalities with ultrasonography, and then immediately termination, it will be helpful. So this is about the polyhydramnios. So let's have a quick summary about polyhydramnios. Polyhydramnios is a state where the amniotic fluid exceeds 1500 ml, and etiology due to fetal anomalies, maternal causes, placental and multiple pregnancies. Clinical types. There are two clinical types: chronic polyhydramnios, acute polyhydramnios. And management, mostly spontaneous abortion occur, or decompression of compression of uterus has to be done, and repeated amniocentesis is done if the pregnancy is continuing. Termination of pregnancy if required. Supportive therapy should be given. And complications, fetal and maternal complications prevention, early detection and control, and genetic counseling in early months. So this is about the polyhydramnios. Hope you have understood. If you have any kinds of doubt, please contact me.